So let's start immediately about the contents about this lecture. So we will have first, we will navigate through some general principles about pharmacology. Then we will go through the ocular pharmacology and understand different concepts about the ocular pharmacology. You can't see or hear? Hello, can you hear my voice? Can you see the slides? Okay. Then we will talk about the relationship between the eye and different organs or different system like the autonomic nervous system, and we will realize what is the relation between the sympathetic and parasympathetic system to the eye. Then we'll talk about the relation between the eye and the intraocular pressure and what are the different drugs that are used to control the intraocular pressure and what are the different mechanisms. Then finally, we will talk about some common ocular drugs like antibiotics, like steroids, anti-inflammatory, and some immunosuppressive drugs because they are asked in the exam. So I know that the lecture will be condensed, so we will divide it into two halves. We will first talk about the general pharmacology, ocular pharmacology, and the eye and the autonomic nervous system in the first part. Then we will take a break. Then we will discuss the anti-glucomatous drugs and other ocular drugs. So starting with the general pharmacology. What are the general principles of pharmacology? If we want to summarize the general pharmacology in two words, then this will be the pharmacokinetics and the pharmacodynamics. So what is meant by the pharmacokinetics and pharmacodynamics? The pharmacokinetics basically means how does the drug moves inside the body. It is the drug trafficking in the body. What is the journey of this drug since it is administered until it is excreted, and what are the factors that will affect the drug concentration inside the body, starting from its first instance with the first contact with the body until it is excreted out of the body. So it is just to study some relationship or some factors that will control the relationship between the drug dose and the changes in concentration. So if we want to know how much does the patient should take, is it 100 milligram, 200 milligram? What is the therapeutic dose? It is 300 milligram, it is 500 milligram. So all these can be controlled by different factors, starting first from the absorption until the excretion. So what is the journey, or what are the stations that the drug will pass through in his journey through the human body? The first of all, or the first station, it is absorbed. After its absorption from the primary organ, then it will be distributed to other organs. So it will be passing through the bloodstream or whatever to different organs. Then the drug will be metabolized in order to reach the final station of excretion. So the metabolism of the drug is like a biotransformation. We transform the drug from active form to inactive form, then it will be excreted outside the body. So here now we come to an important term which is called the bioavailability. So bioavailability means it is the amount of drug that reaches the systemic circulation and becomes available to the site of the drug action. So not 100% of the drug that we take is reaching the target organ, but only a percentage of this drug. This percentage is called the bioavailability. Let me give you an example. When someone has a heart attack, then this person or this patient is advised to take sublingual nitrates or sublingual nitroglycerin. Why this? Because this drug, if it is swallowed, then its effectivity will be less, or its bioavailability will be less. But when it is absorbed through the sublingual vessels, then it will bypass the stomach and bypass the liver, and it will produce its effect much faster. And this patient has very limited time for his heart. That's why it is advisable to give the patient sublingual nitrates. The same thing happens also if a patient, especially if an old patient, is putting an eye drop for glaucoma, that even this drop can cause him death. Can you have a guess? What is an eye drop which can be very dangerous for a patient, or for a glaucomatous patient, that even can cause him death? Let me give you a hint. This drug or this eye drop can affect the heart, or can affect the lungs. Exactly, Dr. Saham. It is the timolol. So the timolol, it is a beta blocker. This beta blocker will block the alpha receptor and beta receptors, cause bronchospasm and cause bradycardia. So if the patient is cardiac, or if the patient has bronchial asthma, then this drug can bypass the systemic circulation by passing through the punctine to the nasolacrimal duct, increasing its systemic absorption, increasing its bioavailability, causing its undesirable side effects on the heart and lung and other organs. So from here you understand what is the importance of bioavailability. So the higher the bioavailability, the more effect of the drug. So here is the journey of the drug. It is absorption, followed by distribution, followed by metabolism, and finally the excretion. So what happens if there is any factor that will increase the absorption of the drug? This will increase its bioavailability. So let's say, for example, that if an eye drop is put on the cornea, and the epithelium, as we know, acts as a barrier. But what happens if there is an epithelial defect? Well, this barrier is no longer here. So this will increase the absorption of the drug, leading to its increasing bioavailability in the eye. And then we have the reverse, like a counteract mechanism. So if the absorption of the, or if the bioavailability of the drug is increased, then the metabolism and the excretion of the drug will be also increased in order to decrease the bioavailability, so that the concentration of the drug in the plasma or in the eye is not constant all the time, but it is increasing and decreasing by different pharmacokinetics. So we need to know what are the factors that will affect each stage of the drug journey. So what are the factors that will affect the absorption? There are different factors, but in the first, we will talk now about what are the mechanisms of the absorption. We said some of them while we were discussing the physiology of the aqueous. So we said that there is a diffusion. So the diffusion is the passage of molecules or passage of drug from area of highest concentration to area of lowest concentration. So it is not against the concentration gradient, it is with concentration gradient. If the drug is needed in much more amount, then there is another mechanism called the carrier molecule, or it is a facilitated diffusion. So it is not a diffusion, but it is facilitated. Why it is facilitated? Because it will be facilitated by a carrier. A carrier molecule will carry the drug and enter inside the cell, and then it will pass the drug across the cell membrane. So, but this shouldn't be confused with the diffusion, because it is again not against the concentration gradient. It is just that the body or the tissue needs much more amount of this drug. So some carrier molecules will donate to carry this drug and enter facilitate the diffusion of the drug into the cell. The third mechanism is called the pinocytosis. And the pinocytosis, it is like invagination of the drug inside the cell, and then It will be prolapsed outside inside the cell, and then it will be protruding outside the cell, as we'll see in a while. Finally, the active transport, this is the energy consuming process in which the drug will pass against the concentration gradient. So let's see this in more animated form. If we have here like a cell membrane or a cell, and then there are different drugs that want to enter inside the cell. So what will be the mechanism? First of all, the diffusion. The diffusion doesn't need anything, just the drug pass simply from areas of high concentration to area of low concentration. Then there is a facilitated diffusion in which the drug will be carried by a carrier. So the drug will be binding to will facilitate the passage of the drug across the cell membrane, and it will enter the drug into the effector or the target organ. The biinocytosis, the drug is becoming adherent to the tissue or the cell membrane. So the cell membrane will invaginate, and the drug will be included inside the cell as a biinocytic vesicle. Then, on the other side or on the other membrane, the drug will try to protrude outside the cell membrane, and then this biinocytic vesicle will rupture so that it will evacuate its content inside the target organ. And this is one of the mechanisms of secretion of aqueous humor. Finally, the active transport. Then the active transport, again, it is one of the mechanisms that also has a carrier. So there is a carrier that will take the drug, but this carrier, in order to action or in order to take the drug inside, then this carrier will need ATP or need energy, and this was what's called the active transport. So facilitated diffusion and active transport needs the carrier, but facilitated diffusion doesn't require energy, while active transport require energy. Can you see the slides? Can you hear my voice? Okay. The diffusion all over the body is controlled by a principle or law called the Fick's law. The Fick's law of diffusion states that the rate of diffusion is equal a constant that's called a coefficient of diffusion multiplied by the A, or the diffusion area, multiplied by the difference between the concentration of the drug in the plasma and the drug inside the cell. So this can be a drug or can be anything. Divided over the thickness of the membrane. So if the coefficient of diffusion is increased, the rate of diffusion will increase. And this coefficient of diffusion will be determined by several factors like the solubility of the drug and the concentration and the molecular weight. There is other factors that we will talk about later. Then the A, which is the, just hold on please. Sorry for the interruption. The second factor will be the diffusion area. So the more the surface area that is available for diffusion, the more the rate of diffusion. This is logic. Then the difference in concentration between the plasma and the intracellular compartment. So the more the difference, the more the diffusion, divided by the thickness of the membrane. So if the membrane is thicker, so the diffusion will be decreased. But if there is a thin membrane, or if it is decreasing or decrease the thickness of the membrane, the rate of diffusion will be more. Now we come to an important term, which is the solubility. Is called the solubility. Solubility meaning that whether the drug is lipid soluble or water soluble. Is it lipophilic or is it hydrophilic? There are other terms for a drug that is lipid soluble. It can be also called non-ionized or non-polar or uncharged. And the water soluble can be termed as ionized or polar or charged. Generally speaking, when we are talking about the eye or even the brain, the drugs that are more lipid soluble have higher penetration inside the eye, because the plasma membrane or the epithelium, sorry, has lipid layer, and the drug can be easily passed through this lipid layer, so that it will be having higher penetration. The water-soluble or the hydrophilic drugs have lower penetration through the epithelium of the cornea. However, the solubility is not the only determining factor for the diffusion, but also the chemical structure of the drug play an important role. For example, if a drug is uncharged or lipid soluble, it can still be, if it is the drug is uncharged, it is still can its penetration will be poor and can be hydrophilic. This is because of its chemical structure. So the chemical structure meaning that, for example, the streptomycin and the aminoglycosides have high hydrogen bond group. And this hydrogen bond will make them hydrophilic, although they are uncharged. Okay, so as we are talking about the general pharmacology, we need to know what are the factors that will affect the absorption of the drug and the bioavailability if the drug is taken from the mouth. So what are the factors that will, concerning the gut or the GIT system, that will affect the bioavailability of the drug? If there is excessive GIT motility, this will decrease the absorption of the drug, as there will be diarrhea. If the food also has an important role, because sometimes the tetracycline can form insoluble salts with magnesium and the calcium, limiting its absorption and limiting its bioavailability. The pH also can increase or decrease the bioavailability of the drug. For example, the penicillin become inactivated by alkaline pH. Absorption area, as we said, through the Fick's principle, if there is increasing of the absorption area, this will increase the diffusion or increase the bioavailability. In Crohn's disease, this will not happen, as there will be decrease in the absorption area. Intestinal blood flow also, if it is increasing, it will increase absorption. Intestinal flora and also enterohepatic circulation will increase. If it is excessive, it will increase the elimination of the drug, leading to decreasing its bioavailability. So based on this principle, or based on the bioavailability concept, then there are some drugs that can be administered in the prodrugs. Prodrugs mean that it is inactive form that is activated inside the body. So for example, the dibipephrine or the propine is a prodrug of the epinephrine or the adrenaline. But this in because it has a better penetration. It is about 17 times better penetration than epinephrine. Also, the nipafinac or the Nivanac eye drops, if you remember this name, it is the prodrug of the Amphenac. So the Nivanac itself, or the nipafinac itself, is not active, but it is activated inside the body. But we give this drug or this prodrugs because they have higher penetration, so that it will give higher bioavailability. So what happens after the drug is absorbed? Then the drug should be distributed. And the distribution, the surprise is that the drug is not distributed to all different organs of the body to the same level, meaning that there is a certain factor that will control the concentration of the drug that reach each organ. This is, logically speaking, it is the blood flow. So if there is an organ which is well perfused and has excessive blood flow, then this organ will have a great share of the drug concentration, and vice versa. If the organ is not well perfused and it doesn't receive an ample blood supply, this will result in decreasing the concentration of the drug at this organ. Also aside the eye, so if you see that this is an infective keratitis, this is a localized infective keratitis in the paracentral region, and although it looks severe and it looks like the eye is injected, but we don't give systemic drugs in this case. And why this? Because the cornea is avascular, so the cornea is not well perfused. So if you give a systemic antibiotic, then this will result in that this systemic antibiotic will not reach the cornea in a concentration that will inhibit the growth of the organism. So the better solution is to give a topical intensive antibiotics, not systemic. But if the infiltration or if the infection is near the limbus, like this, like here, then here there is a rule for systemic antibiotics. So this is based on the principle of distribution. The distribution is just simply is the amount of the drug that reach each organ inside the body. And here we come to an important term, which is called the biological half-life. The biological half-life, or the T-half, it is the period during which the plasma concentration of a drug reaches half of its concentration. So that as we give the drug is not steady. So it doesn't reach a peak and then stay still, but it will increase in the concentration. Then it will reach a peak. Then it will decrease until it is eliminated from inside the body. The time that the plasma concentration of the drug reach half of its concentration, let's say, for example, that this is the time, if this is the time, like here, the concentration through the blood is half percent, it is 50%, then this is called the half-life of the drug. So the half-life of the drug is an important term because it will determine what is the frequency of the drug. Should we take this drug once daily, twice daily, 4 times daily? What is the limiting factor here when the drug is eliminated from the circulation? What is the T-half of this drug? So also, if this principle can control if we need to give the drug in a loading dose or not. So if, for example, there are some drugs like the ganciclovir can be given in a loading dose for a few days in order to reach a therapeutic response or therapeutic level, because this or doesn't reach a concentration very rapidly. So we need to excessively increase the dosage of this drug. So as we talked about the factors controlling the diffusion, we need to know what are the factors that will control the distribution. Again, the physical and the chemical properties of the drug, if it is water soluble or lipid soluble, as I told you, there are some organs that have a lipid cell membrane that will, this lipid cell membrane will favor the diffusion and favor the distribution of the lipid soluble drug. Also, the molecular size, it goes without saying that if it is the smaller the molecular size of the drug, the better the distribution. Also, an important factor here is the binding to the plasma protein. So usually the drug doesn't pass or doesn't circulate freely in the bloodstream, but it is bound to plasma proteins. So what happens if these plasma proteins are increased? If they are increased, this means that the drug is, more of the drug is bound to plasma protein. So like this, suppose that these are plasma protein and this is the drug. So the increase in the plasma protein leading to increased binding of the drug to the plasma protein. So that when the plasma protein, this is called the bound drug. But actually what is effective, it is called the free drug. So the free drug goes to the cell and does its action on the cell. So the more the bound drug, the less the free drug. So by increasing the plasma protein, this will decrease the drug distribution to the tissues, so it will leading to decrease its action. The reverse occur if there is a disease that will cause decreased plasma proteins, like for example, like renal failure. This will result in decrease the amount of plasma proteins, so there will be decrease of the amount of bound drug, leading to increase the amount of free drug, causing its excessive action and more distribution to the tissues, causing more effective action. So this should be taken into consideration in the patients with renal failure, because dose of the drug should be adjusted to compensate for this decrease in the plasma proteins. Otherwise, they will suffer from drug toxicity. Also, we mentioned about something about this when we were talking about the vitamin A metabolism. So we said that the vitamin A, after absorption and passing into the liver, it will be bind to a plasma protein, the RP. So it is the same concept. Any drug will be bind to a plasma protein. Also binding to tissue proteins, like there are, as also we said in the vitamin A, there is interstitial retinoid binding protein. The blood flow to the tissues also, the more the blood flow, as we said, the more the distribution. Talking about the eye has some other factors. The eye has what's called barrier. We talked about them more than once. There is a barrier present at the area of ciliary epithelium. That's called the blood aqueous barrier, and there is a barrier present at the area of retina. It's called the blood retinal barrier. So what is the function of these barriers? The blood aqueous barrier and the blood retinal barrier here in the blood aqueous, it is the non-pigmented epithelial cells, and in the blood retinal barrier, it is the RPE cells and the blood vessels. So it will be between the iris blood vessels and the non-pigmented ciliary epithelium, and it will be between the retinal capillaries and the tight junction between the RPE cells. The function of these barriers are to limit the passage of large molecules, to passage of some hazardous material, to prevent the passage of microorganisms inside the eye. So these barriers are a barrier to almost all molecules except the lipophilic molecules. So as we said, the lipophilic has a better absorption and also have a better penetration. So the barrier is not capable to block the lipophilic molecules to enter inside the eye. These barriers are broken during the process of inflammation or trauma or injury that will lead to breakage of the blood aqueous barrier or blood retinal barrier. And as we mentioned before, this can be a blessing and a curse at the same time, meaning that it can bring the anti-inflammatory drugs inside the eye, so it will combat the infection. But on the other hand, it will interfere with the visibility or interfere with vision, as in case of the blood aqueous barrier causing plasmoid aqueous and the plasma protein to enter inside the eye. So this is the fact about the blood aqueous and the blood retinal barrier. There are other drugs that when are given orally, they are able to penetrate the blood aqueous barrier and blood retinal barriers. These are some antibiotics like the ciprofloxacin and the chloramphenicol, and the non-steroidal and steroidal anti-inflammatory drugs. Maybe this is why we are giving, or some surgeons advocated to give ciprofloxacin in the perioperative period, in the phacoemulsification surgery or in cataract surgery, before and after surgery, because it is believed that the ciprofloxacin also before the operation, the blood ocular barriers are intact, but the ciprofloxacin is still able to reach a high concentration within the eye, and also the other drugs like chloramphenicol, non-steroidal and steroidal drugs. Other drugs that cannot penetrate inside the eye are the fluorescein dye. So fluorescein dye, when given intravenous, as during the fluorescein angiography, they will circulate through all over the body and will reach the choroidal circulation and the retinal circulation. They will leak outside the choroidal circulation or the choriocapillaries since they are fenestrated, but they will not leak outside the retinal circulation, retinal barrier. So if this barrier is breached, like for example, if there is inflammation, or for example, if there is leakage, or there is diabetic retinopathy or CNV, these diseases will cause break of the blood retinal barrier, causing diffusion of the dye outside the retinal vessel, causing the characteristic hyperfluorescence of different diseases. Also, if there is a drug that is bound to plasma protein, it will not be able to penetrate inside the eye. The metabolism, the third stage of the pharmacokinetics, is the metabolism. Metabolism meaning that it is a biotransformation of the drug. Now the drug will not be active forever, but it will sooner or later, it will be metabolized by the liver, and in order to make it inactive. So changing the drug into inactive form or hydrophilic form for easily excretion. This is called the metabolism. Again, it is the metabolism. It is the change of the lipophilic drugs in the liver into either hydrophilic or inactive form in order to be easily excreted. This happens specifically at the smooth endoplasmic reticulum of the liver cells, because the smooth endoplasmic reticulum of the liver cells have some enzymes that are capable to metabolize the drugs. They will undergo two phases. The phase one, it's called the modification. There is this modification by the liver in the smooth endoplasmic reticulum, there is some enzymes are called the microsomal enzymes. The most famous one is called the cytochrome P450. There is microsomal, they are called the cytochrome P450. This is responsible for metabolism of most of the drugs. There are some enzymes that are not present in the smooth endoplasmic reticulum and is called non-microsomal, like the monoamine oxidase. After the drug has been metabolized or modified first by the microsomal enzymes, it would undergo a next stage or a next phase called the conjugation. So in which the liver will conjugate the drug with different compounds like the glucuronic acid, like the glycine, like the glutamate, and the others, in order to inactivate it or making it more hydrophilic. So what increase the metabolism and what decrease the metabolism? Most of the factors that will control the metabolism will act on the enzymes, like the microsomal enzymes or specifically the cytochrome P450. There are some drugs that will cause increase of the effect of these enzymes, leading to increasing the action of the cytochrome P450, leading to more metabolism of the drug, leading to decrease its bioavailability and decrease its concentration. These drugs are called, or these factors are called enzyme inducers. On the other hand, there are other factors that will cause inhibition of these enzymes. So they will cause inhibition of the cytochrome P450, leading to inhibition of the metabolism, causing increase the amount of the drug concentration. So these are called enzyme inhibitors. There are different drugs that cause enzyme induction or enzyme inhibition, so you need to know about them. So common enzyme inducers are the rifampicin, the griseofulvin, the barbiturate, the phenothiazine, the phenytoin, the nicotine. These are called enzyme inducers that will induce or increase the activity of cytochrome P450, causing more metabolism. On the other hand, there are other drugs that will cause what's called enzyme inhibition or lead to enzyme inhibition, leading to decreasing the metabolism and increase the availability of the drug, like the isoniazid or INH, chloramphenicol, metronidazole, and warfarin. Other factors that will control the metabolism are age. So these enzymes, like for example, the conjugating enzymes are not very well developed in the neonates. So that these enzymes will not be able to metabolize the drugs during in the early neonatal life, leading to decreasing in the metabolism and increasing the concentration of the drug. So this is very important because this can cause toxicity. And that's why we need to adjust the dose in neonates. We need to adjust the dose of if these neonates are given a drug, we need to decrease the dose because they still are not able to metabolize these drugs because of the deficiency in the conjugating enzymes. The smoking is causing enzyme induction, so it will increase the metabolism, leading to decrease the drug concentration. On the other hand, the alcoholism can cause enzyme inhibition, so the alcoholism would increase the amount of drug concentration. Nutritional state and some genetic factor like glucose 6-phosphate dehydrogenase deficiency will also affect the metabolism of some drugs, like for example for G6PD deficiency, it will affect the sulfur. So the sulfur can affect the RBCs, which are under stress by G6PD deficiency, causing hemolysis and causing hemolytic anemia. Finally, the drug now we will come to the final stage, which is excretion. After it has been metabolized to inactive form or to hydrophilic form, then most of the drugs will be excreted outside the body by the kidneys. So the kidney can excrete the drug percent. So as the drug will pass from the bloodstream to the glomeruli will form a filtration or will filtrate this blood. This can be will be the main mechanism, specifically if the drug is not bound to plasma protein, so it is free, and it is of a smaller size. So the more smaller, the more it is free, the more it will be bound to the glomeruli or will be filtrated by the glomeruli into the mainstream. Or secretion. So the secretion is a mechanism, another mechanism for excretion of the drug, which but doesn't happen in the glomeruli, but it happens at the tubules. So the drugs can be secreted through the tubules inside in the kidney, and there will be so for example, there will be a competition at certain locations by some drugs and other drugs. So this active secretion by this competitive competition between the drugs will cause some drugs to be excreted through the tubules inside into the urine stream immediately without need to be filtered through the glomeruli. So again, the secretion means that there are some certain locations at the tubules, like proximal convoluted tubules and the distal tubules, will have receptors for the drugs. The drugs will compete for these receptors, and once there is a drug will bind to a receptor, this receptor will make this drug pass through the urine stream immediately without need to pass through the glomeruli. Finally, reabsorption. Reabsorption meaning that there are large amounts of water that are absorbed by the nephron. So these large amounts of water will help also to facilitate the excretion of the drugs. The second mechanism will be the bile excretion. There are certain drugs that are excreted through the bile. So from the liver, they will pass to the biliary duct or to the gallbladder and to the biliary duct. So, like for example, the rifampicin. The rifampicin is conjugated in the liver in order, so it is metabolized in the liver. Then it will be passed through the liver, from the liver to the intestine, and from the intestine to the stool. However, there are some parts of the rifampicin will be back, so it will be returned back in order to reconjugated and resecreted. So this is called the enterohepatic circulation. So this is the conjugated drugs are concentrated here in the bile, and then it will pass, or it will be delivered to the intestine, where it will be in the intestine, it will be hydrolyzed and it will be passing through the stool, but there are some parts of the drug will be returning back in order to through the enterohepatic circulation, where it will recirculate again and it will re-excrete again. Then the second part of the general pharmacology is called the pharmacodynamics. So the dynamics means that how does the body handle the drug? What are the actions of the drug? What is its physiological effect at its target organ? And how does the drug do its mechanism of action? In order to understand the pharmacodynamics, we need to understand what are the different mechanisms of action of the drug. Let's say, for example, that we have 3 drugs here. If the drug is bind to a receptor, causing firing of the response, causing the complete action, leading to, or the maximum action that is, or the maximum stimulation of this receptor and this organ, then this drug is called a full agonist. So a full agonist means that this is a maximum response. On the other hand, if the drug is bound to a receptor, and this will cause a triggering, or this will trigger a response that it is not complete or a partial response, then this is called a partial agonist. But if the drug is bound to a receptor and it will cause not only inhibition, but it will cause antagonizing the action, then this will cause what is called antagonist. Let's take an example. If this receptor is present at the sphincter pupillae muscle, if the drug is called full meiosis, so the pupil is pinpoint, it is called full agonist, or the drug is called a full agonist. If the patient take an eye drop or a drug that will called mild meiosis, so it will cause meiosis, but it is now it is a not complete meiosis, then it is called the partial agonist. If the drug which is administered to the eye will act on the sphincter pupillae muscle, causing its relaxation, resulting in mydriasis, then so for first example, this is atropine, the pilocarpine, for example. This can be called an agonist in the sphincter pupillae muscle, and the antagonist will be like the atropine. So atropine will cause dilatation of the sphincter pupillae muscle through its antagonistic action on the sphincter pupillae muscle. Also, there is a relationship between the agonist and antagonist. So what is this relationship? If we have an agonist-antagonist, and these drugs are both trying to bind to a receptor. If there is the agonist is binding, and when the antagonist is trying to bind the receptor, this will result in that the antagonist will be kicked out of the receptor. Then this is called the competitive action. So both the agonist and antagonist are mutually exclusive. Any one of them will exclude the other from the receptor. The receptor can't be bound to both of them at the same time. This is called the competitive action. On the other hand, if both the agonist and antagonist can bind to the receptor at the same time, so they will be just bound to the same receptor but different locations, so it will be called non-competitive interaction or non-competitive relationship between the agonist and the antagonist. From here we have some important definitions, which is the efficacy and the potency. The efficacy means that the maximum response the drug can give. So the drug, when a drug is given to the patient, what is the maximum response? What is the highest response that this treatment? This is used with the potency. Potency, it is the amount of the drug required to give desired response. So for example, a drug can be high, so it can give very high response, potent, because in order to give we need to give a high amount of the drug. So we can say that the potency, meaning that it is the smallest amount of the drug that are required in order to give the desired response. So for example, if you have a bacteria, and this bacteria, we have an antibiotic A called antibiotic A and the antibiotic B. If we increase the dose of the antibiotic A and the antibiotic B, we can find that the antibiotic A is always having a higher response or higher effect than the antibiotic B. So the effect here favors the drug A. So the antibiotic A is more efficient. It will give higher response. Let's say, for example, that the antibiotic A will kill 100% of the bacteria, but the antibiotic B will only kill 80% of the bacteria. But this happened at the same time, or with the same dose. So let's say the antibiotic A was given about 1 gram, and also the drug B is given at a dose of 1 gram. So in this occasion, or in this instance, we can say that the drug A is more efficient, or more, the efficiency is more for the drug A than drug B. But on the other hand, in this scenario, when we give the drug A and the drug B, they have both reached the same efficiency. So both of them can kill 100% of bacteria. But the drug A has been able to do so with a minimum dose. So like say, for example, it's about 1 gram in order to be very efficient. But for drug B, as we increase the dose, it is still not efficient. As we increase the dose, it is still not efficient. Now it is becoming more efficient. So although it reached the same efficiency like antibiotic A, but this has happened only by increasing the dose to about 3 grams. So this means that the drug A is able to achieve the clinical response with a minimum dose. So the drug A is more potent than drug B. I hope that this concept is clear to you. Other important definitions are the tolerance. So tolerance is a well-known phenomenon in pharmacology, meaning that it is just the effector organ become tolerant to the drug, meaning that as we give the drug in the first instance, there is a response. As we increase as we give the drug in successive days, the receptors of the drugs are tolerant to the effect of the drug. So the drug doesn't give its effect anymore. So in order to overcome this, we need to increase the dose in order to reach the same therapeutic response that the drug used to give in the older days. So tolerance meaning that there is decrease in the efficacy of the drug with time. Therapeutic index meaning that it is a method to compare between the different antibiotics. So we can measure the relative effective or therapeutic concentration of antibiotic at the target site against a target organism. This is called the important inhibitory quotient, or sometimes referred as a minimum inhibitory concentration. It is the most potent antibiotic, or it is the lowest concentration of an antimicrobial, like for example an antifungal, antibiotic, or antiviral, that will give the therapeutic response, which is inhibition of the growth of microorganisms. So again, it is the minimum inhibitory concentration or the inhibitory quotient. It is the lowest drug concentration that will give the maximum response, which is defined specifically by inhibition of the growth of microorganisms. So if we have an incubator, or we have a plate that have some staff, and we put an antibiotic, this antibiotic is antibiotic A. What is the minimum amount of this antibiotic that will inhibit the growth of these bacteria over the night, or over night incubation? This is called the inhibitory quotient or minimum inhibitory concentration. So it is like about a ratio between the drug exposure to the viral susceptibility. It is the drug is more potent, or are the drug or are the bacteria are more virulent? So this is the first part, which is the general pharmacology. I hope that everything is clear up till now. If you have a question, you can ask in the chat box. Okay, so let's jump immediately to the ocular pharmacology. In ocular pharmacology, we'll talk about ocular permeability of the drugs. So what are the factors that will control the ocular, specifically ocular permeability of the drugs, and what are the routes of drug administration as considered to the eye, And what are the ocular toxicity from systemic drugs? Let's start first by ocular permeability. If we have a drug that we want to increase its permeability to the eye, what can we do? We have many options. First of all, we can simply increase its concentration. So instead of giving it in 50%, we can give it by 100%. But does this rule is valid all the time? The answer is no, because we are limited by the solubility of the drug. So it is insoluble. Even if you increase the concentration, it is still will not penetrate properly. Also the tonicity. Also the reflex tearing. If the drug is irritant and cause reflex tearing, this will cause washout of the drug. Adding a surfactant or what's called the preservatives of the eye, like the benzalkonium hydrochloride. The benzalkonium hydrochloride will cause breakage or will cause break of the epithelium of the permeability of the drug to the cornea. This kind of compound that will be added to almost every eye drops which is preserved, so that it will preserve the structure of the end of the eye drop after. It will also alter the tonicity, making hypertonic or hypotonic, leading change of the ocular permeability. Increasing the pH will affect also the permeability, as there will be the increasing the pH will increase the non-ionized or the lipophilic or the liposoluble form of the drug, which will increase the penetration. So we know this rule, that increasing the lipid form or the lipid soluble of the drug will increase the penetration, and this happens more with the high pH. Also increasing the viscosity of the drug. So instead of having a watery eye drop, we can give a viscous eye drop like the methylcellulose or polyvinyl alcohol bases that are added to artificial tears in order to increase the contact time. Also, we can increase the contact time by changing the form of the drug itself, not only the content, by making the drug in a gel form or an oint form, leading to extended contact time between the drug and the eye. Punctal occlusion will inhibit the drainage or will decrease the drainage. So by occlusion of the punctum after the drop, this will cause decrease the drainage and also has an advantage of decreasing the systemic absorption. Increasing the frequency, of course, and the solubility. So the higher the lipid solubility, the more the penetration. Some important notes about corneal penetration. We have some drugs that are called the biphasic drugs. These drugs have a lipophilic component and the hydrophilic component, which will enable them to have the highest penetration. So the lipophilic component will pass through the epithelium and the hydrophilic will pass through the stroma, so that it will have the highest penetration to the body, like for example the dilating eye drops, which are the tropicamide and cyclopentolate. This will reach the iris easily and rapidly because they are biphasic drugs. Also, as we mentioned, the permeability will increase with epithelial defect or will cause damage the bonds between the cells. The stroma has a diffusion rate of about 1/4 of that of the aqueous system, and the non-steroidal anti-inflammatory drugs and the pyrocarpine accumulate in the cornea. This is for MCQs. So these are some rapid points for the MCQ. Lipophilic drug reservoir is the corneal epithelium. The corneal epithelium can be considered as a lipophilic drug reservoir because the 1/3 of the plasma membrane mass of the cornea. So the plasma membrane contains lipids. So that the diffusion of the lipophilic drugs will depend on the amount of lipid inside the plasma membrane. Since the amount of lipid in the plasma membrane is high, the drugs will be stored in the epithelium of the cornea, leading to slow continuous release into the aqueous. This slow continuous release in the aqueous will depend on how much this lipophilic drug will change into the hydrophilic form. So again, if you are confused, lipophilic drug reservoir, meaning that the corneal epithelium act as a reservoir for drugs, because specifically for the lipophilic drugs, because the corneal epithelium has high lipid content. So the drug now is stored within the corneal epithelium, and it is released slowly into the aqueous, and this release will depend mainly on how much of this lipophilic drug will convert to hydrophilic form. The ionized drug or the hydrophilic drug can pass through the cornea if there is an epithelial defect, leading to binding to melanin of the iris and ciliary body. So since it is bound to melanin of the iris and ciliary body, it will show slow release. So this causes prolonged effect, but it will also be minimum effect. So it cannot produce the full therapeutic response because it will show continuous slow release of the drug. Sometimes there are some drugs that cannot pass through the cornea, so they can be given subconjunctival. For example, if you can see there are some doctors who prefer to give subconjunctival antibiotics after the cataract surgery. So why they are just not pour it over the surface of the cornea? Because they may not pass greatly through the cornea, so the sclera can have higher permeability than the cornea. If you wanted to treat a problem in the vitreous, like for example, like an endophthalmitis, the topical drugs will not be the best option because the topical drugs will reach poorly to the vitreous because they will have to pass against the aqueous gradient. So, for example, this is the eye. If we put an eye drop here, so the aqueous is passing from posterior to anterior, to be drained through the trabecular meshwork. But the drug should pass in the reverse direction from anterior to posterior in order to reach the vitreous. Also, the vitreous itself has will show slow diffusion of the drug into the vitreous. So even if the drug is reaching the vitreous, it will slowly diffuse to different parts of the vitreous. That's why the topical drugs usually don't reach an effective concentration inside the vitreous, and they are not recommended to use in case of intraocular inflammation or endophthalmitis. As we mentioned, the nasolacrimal duct has also a role in drug drainage. So if we put a drug into the eye drops or eye drops inside the eye, this will result in drainage through the pancreas into the nasolacrimal duct. The passage of the drug through the pancreas to the nasolacrimal duct will cause systemic absorption and sometimes lead to undesirable systemic side effects. So in order to block the systemic absorption, we can press by the finger over the pancreas for 5 minutes after the drop administration. This will result in decreasing the drainage and decreasing also the systemic absorption. Talking about preservatives, what are the preservatives? Preservatives are compounds that are added to the eye drops and eye ointments to keep them sterile. Advantage of sterile, but the disadvantage that they will disrupt the tear film and will cause break of the epithelial barrier. For example, the benzyl cholium chloride, the chlorbutol, the thimerosal, and the phenyl mercuric nitrate, and the chlorhexidine and sorbic acid. The most famous one is the benzyl cholium hydrochloride. It is a bactericidal. So it has a role to disinfect the eye drops by attaching to the bacterial cell wall. If a bacteria enter inside the eye drop, it will break its cell wall, leading to its increasing permeability of the bacteria, leading to rupture of the bacteria. So it will assume a bactericidal effect over the bacteria. But it has some side effects, cellular damage and allergy. And that's why it is not advocated to that the patient will put the avoid toxicity of chloride over the eye. So it is reported that these preservatives will cause cellular toxicity or epithelial toxicity. Also note that the benzalkonium is effective in alkaline pH. So if the pH is acidic, then it will be inactivated. Also, the benzalkonium is inactivated by soaps and salts like the magnesium and calcium salt. Other preservatives which are less commonly used than the benzalkonium are the chlorbutol, which has a problem of decreasing oxygen consumption by the cornea, leading to core epithelium desquamation. So it will devitalize the corneal epithelium. Another preservative is called the thimercel or phenyl mercuric nitrate. It has a problem of having mercury. This mercury will cause allergy and will cause some deposits over the cornea. Now let's talk about the drug delivery in ophthalmology. What's called the drug vehicle? How is the drug is transferred to inside the eye? We have different routes of drug administration in ophthalmology. For example, the topical, the periocular, the intraocular, and the systemic. The topical meaning that it can be either in the form of eye drop or eye ointment or eye gel. The periocular or injection, not intraocular, but around the eye, it can be subconjunctival, subtenon, peribulbar, and retrobulbar. Intraocular can be either inside the anterior chamber or intracameral, or in the vitreous or intravitreal. Or for some instance, we need to give the patient systemic drugs, which can be either given oral or intravenous or intramuscular. So here are the different routes. It can be either topical administration in the form of eye drop or an eye ointment or eye gel, or it can be periocular. The periocular can be either subconjunctival or subtenon or peribulbar or periocular or retrobulbar. Or it can be intraocular, like intravitreal inside the vitreous, or intracameral inside the anterior chamber. Or it can be given systemic, like intravenous or intramuscular or oral. So when do we give each type or each form? What are the requirements or what are the indications of giving a drug in a certain route? I will just, excuse me, I'll just be back in 1 minute. Please hold on. Sorry for the interruption. Just difficult to have a baby at home. Okay, so the topical eye drops. The topical eye drops are the simplest method for administering an eye drop. Let's say, for example, that this is the most common and the most convenient method for administration of the an ocular medication. So the patient can take it at very convenient times, at very sometimes the patient put the eye drops in his eyes and there is a spillage over of the eye drops. And then we wonder whether these eye drops are now is effective or not. Let me tell you something, that this eye drop, the single eye drop, it has a volume of about 50 microliter, while the conjunctival sac capacity is about maximum 30 microliter. So even one drop is more than enough. So if you find that the eye drop is spilled over the eye, then don't worry, the eye drop will cause its action. Also, the problem with adding much more eye drops, if you are suspicious about the effect of the eye drop and you put more eye drops, this will increase the amount of eye drop that will be excreted through the eye, which will pass through the nasolacrimal duct and leading to increased systemic absorption and increased systemic toxicity. To administer more than one eye drop. The second method of the topical application is called the ointment. So the ointment has an advantage of increasing the contact time to the ocular surface, so that it will have extended action. That's why we prefer to do night, so that the patient will have a continuous action of the medication overnight. But it has a problem of vision blurring, so that it is sometimes be annoying to the patient to use ointments in the morning. The drug or the ointment has high lipid solubility with some water solubility, or in other words, to be biphasic. That's how the drug will exert its maximum effect of penetration and will exert its maximum contact time. The periocular injection is a good route for drugs that have poor lipid solubility and water solubility. So if there is a drug that we want to administer to the cornea or to the eye that has a poor lipid solubility, and we want to bypass the cornea and the conjunctival epithelium, then here is the way to go, which is the periocular injection. There are several drugs that can be administered through this method, including the steroids. The local anesthetics, as you can see here, can be applied through this way. For example, the subconjunctival injection lead to achieving of higher concentration in drugs that cannot penetrate the cornea due to their large molecular size. As I told you, the penetration through the sclera is easier, so this will result in increasing the concentration of the drug. Also, the subtenon. We can inject the subtenon specifically, especially the anesthesia can be given in the subtenon space, and also steroids can be given in the subtenon space, especially for patients who have intermediate uveitis. Retrobulbar injection also have been reported and can be used for the uveitis. In the clinical, we will say that the term of uveitis can include optic neuritis and papillitis and posterior uveitis, and also can be given for anesthesia. Peripulbar anesthesia also can be given by the same way. Intraocular injection also is a method for drug administration for several purposes. For example, intracameral injection of acetylcholine or myocol. This is a common intraocular procedure during the cataract surgery, so that we want to constrict the pupil immediately and rapidly. This can be done by injection of intracameral or a myotic inside the anterior chamber. Intravitreal injection is also one of the most common procedures performed in ophthalmology by injection of antibiotics in case of endophthalmitis, or by triamcinolone or steroids in case of macular edema, or anti-VEGF or antivascular endothelial growth factors in diabetic retinopathy. Another method which gained more popularity is called the sustained release device. If you want the drug to have a continuous action, we can put a device that slowly release the drug that we want. For example, if patients who have glaucoma can have a device that's called OcuSert. This OcuSert is inserted into the fornix, and it is responsible for continuous release of pilocarpine. Also, there is another more important indication, which is the ganciclovir sustained release intraocular device for patients who have cytomegalovirus retinitis, and these patients are not responding well to the topical medications, or excuse me, for the systemic medications, in which we implant an intravitreal device. It's called the ganciclovir implant that release continuous release of ganciclovir antiviral. Hello, can you see the slides or not? Can you see the slides and the sound clearly or not? Okay, so I'm just want to make sure, because if it is just interrupted, then it will be good at the recording. But if it is a general problem, so if you are all reporting the same thing, then it will be a problem. And we'll try. This means that it will not be recorded. So I guess we are okay. Now let's talk about the ocular toxicity. There, as we mentioned, the ocular medications can have some systemic absorption. This systemic absorption can lead to some undesirable side effects. Can you all hear the echo? Do you hear an echo in my voice? Okay. So as we mentioned, as we give an example about timolol, we said that the timolol can cause death. This is because if the patient is having some cardiac problem or respiratory problems, this will result in bronchospasm or bradycardia until even systole, causing death, even with a single eye drop. The local side effects or the local toxic effects can be in the form of hypersensitivity reactions, especially for some drugs, as anti-glaucomatous drugs like alpha-2 agonists can cause irritation to the surface of the eye. Preservatives of the eye or contact lens solutions can also produce the same local toxic effect. The benzalkonium chloride can cause punctate keratopathy, and thimerosal can cause hypersensitivity reactions. So many of the local side effects are due to the use of the preservatives of the eye drops. Here we come to some maybe not very favorable part for many of us, which is the drugs. Here we need to have to memorize some of these drugs, but these are the most common drugs asked in the exams, and what are the commonest ocular side effects. The topiramate is a drug that is antidepressant that was associated with angle closure glaucoma. So this is one of the commonest side effects about this topiramate. Hydroxychloroquine and the chloroquines are antimalarials are associated with the chloroquine amblyopia because they cause a disease called bullseye maculopathy. Tamoxifen, which is anti-tumor necrosis factor, will cause a crystalline maculopathy. Vigabatrin is an anticonvulsant which is causing progressive and permanent bilateral concentric visual field constriction. It usually starts with the nasal hemianopia. Sildenafil or Viagra will cause a non-arthritic ischemic optic neuropathy, causing sudden visual loss. Anti-tuberculous drugs like ethambutol, chloramphenicol, rifampicin are famous for their action on the optic nerve. So they will cause toxic optic neuropathy presenting with the central visual loss and the central or centrocecal scotoma. Ocular steroids are characterized by development of cataract and glaucoma. So I will just illustrate some of these drugs, not all, but some of these drugs with their side effects so that it can be imprinted in your mind. The amiodarone is anti-arrhythmic drugs given for patients with arrhythmia that can result in a fundus lesion and a corneal lesion. The fundus lesion is an optic neuropathy, and the corneal lesion is called the vortex keratopathy or cornea verticillata, which appear as this horn-shaped pigmented deposits in the corneal epithelium. The same thing with amiodarone occurs with the chloroquine. So the chloroquine is a group of drugs that are called anti-malaria drugs used for malaria or rheumatoid arthritis and systemic lupus that comprises of chloroquine and hydroxychloroquine that also cause a corneal lesion and the fundus lesion. The fundus lesion here is called the bullseye maculopathy, while the corneal lesion is called the cornea verticillata or vortex keratopathy. Digitalis is also associated with a very characteristic side effects in which there is an impairment in the yellow color, or it is given for the heart failure associated with the yellowish discoloration in which it's called the chromatopsia. It is a xenopsia or xanthopsia. The xanthopsia meaning that there is a yellowish discoloration due to the overdosage of digitalis. So once the patient is taking digitalis, we should we should instruct him that if he can see the signs in yellowish discoloration, then this means that there is an overdose of the digitalis, which can be sometimes fatal. The thioridazine are an antipsychotic drugs characterized by presence of pigmentary changes or pigmentary retinopathy in the fundus. And as we said, the ethambutol, it is an antituberculous drug nerve toxic optic neuropathy. So it can cause, as you can see here, pallor of the optic nerve and can cause the central and the centrocecal scotoma, leading to visual loss. So let's now move to the final part of the first lecture, which is the eye and autonomic nervous system. What are the relation between the eye and the parasympathetic system and the sympathetic system? Let's first have an idea about the Dr. Sam is asking about which of these toxicity is reversible. Usually, these toxicity are reversible at early stages. So it is more of dose related rather than the drug related. So let's talk about now what are the relationship between the sympathetic and the parasympathetic to the eye. So here we have the parasympathetic and sympathetic system. So first of all, let's have a quick reminder about the structure of the parasympathetic system and the sympathetic system. In the parasympathetic system, there is a preganglionic nerve. This preganglionic nerve is called the preganglionic parasympathetic. Say, for example, in the eye, the ciliary ganglion. There is a neuromuscular junction, or there is sorry, it is not a muscular. There is a receptor inside this ganglia. This receptor are called nicotinic receptors, and the kind of neurotransmitter here is called the acetylcholine. So what happens in the ciliary ganglion is that there is a relay between the preganglionic parasympathetic nerve and the postganglionic parasympathetic nerve, at which there is acetylcholine neurotransmitter is acting upon nicotinic receptors. Then the postganglionic arrives from the ciliary ganglion or the parasympathetic ganglion in order to act on its effector organ. For example, let's say it is the constrictor pupillae muscle. So there is a junction between the nerve and the muscle. This is called the neuromuscular junction. In the neuromuscular junction, the acetylcholine is released again as a neurotransmitter in order to act on the receptor on the constrictor pupillae muscle, but these receptors are now called the muscarinic receptors. Not nicotinic, but they are muscarinic receptors. And if the acetylcholine is acting upon these muscarinic receptors, this will result in parasympathetic effect, as in case of the constrictor pupillae muscle, this will result in constriction of the pupil. So if there is a drug or an action that will cause promotion of this parasympathetic action, or it will cause a stimulation of this parasympathetic effect, then this drug is called the parasympathomimetic. If there is a drug that will cause inhibition or reverse this parasympathetic action, will antagonize the parasympathetic effect, then it is called the parasympatholytic. Likewise, in the sympathetic adrenergic system, there is a preganglionic nerve. The preganglionic nerve will reach the sympathetic ganglion, which, for example, the superior cervical ganglion. The superior cervical ganglion has nicotinic receptors, upon which acetylcholine again act on the nicotinic receptors in the superior cervical ganglion. So please bear in mind that the acetylcholine is present in the ganglion of the parasympathetic and in the sympathetic. Don't be confused. Thinking of the acetylcholine is exclusive for the parasympathetic. It is present in the nicotinic and in the sympathetic ganglion. Okay, so what happens next is the preganglionic sympathetic nerve relay in the sympathetic ganglion. Through the acetylcholine will be released. It will stimulate the postganglionic sympathetic nerve. Then the postganglionic sympathetic nerve now will bind to the effector organ. Let's say, for example, it is the dilator pupillae muscle. So the dilator pupillae muscle have receptors. These are alpha and beta receptors. It has only alpha receptors, but we will just hypothetically, as we talk about any sympathetic organ, it will have an alpha and the beta receptors. So now this nerve, or the postganglionic nerve, will release its neurotransmitter. This neurotransmitter will be the noradrenaline or the norepinephrine. This norepinephrine will act on the alpha receptor and the beta receptors, causing stimulation. So if this is a dilator pupillae muscle, this will result in dilatation of the pupil. So if there is a drug that will promote the sympathetic effect, then this drug will be called a sympathomimetic. If there is a drug that will antagonize the sympathetic action over the sympathetic system, then it will be called the sympatholytic. So here now we know what are the ocular autonomic receptors within the eye. Most of the receptors are confined to the pupil and the ciliary process. So most of the receptors are associated with the control of the pupil size, either by meiosis or mydriasis, or by control of the aqueous formation and outflow. For example, the dilator pupillae muscle has only alpha-1 receptor, so it will cause mydriasis. Iris sphincter has parasympathetic fibers or parasympathetic receptors causing meiosis. The ciliary muscle has parasympathetic receptors causing accommodation, or if there is a muscarinic action, this will result in accommodation. The ciliary process has beta 2 receptors. These beta 2 receptors, by stimulation, will increase the aqueous formation, and by blockage or by inhibition of the beta 2 receptor, this will result in decreased aqueous formation. So it can be beta blocker can be used for as antiglucomatous drugs. The beta 2 also can cause increase the outflow. So, and the alpha 1 can cause also the outflow or stimulation of the beta 2, and alpha 1 can cause increasing the outflow of the aqueous. The blood vessels can constrict by the effect of alpha 1 stimulation, and they can dilate by the effect of beta 2 the stimulation. Lacrimal gland, as we mentioned before, are under the effect of the lacrimal nerve, which carry parasympathetic nerves coming from the pterygopalatine ganglion, and this will result in increasing its secretion. While they have blood supply, the blood vessels are under the sympathetic system, which will also control the secretion. Molar muscle, it is a sympathetically innervated muscle which has alpha 1 receptor that will constrict under retraction. This is what patients with thyroid, why they have lid retraction. This is because the thyroid gland stimulates the sympathetic system, causing stimulation of the alpha 1 receptor in the molar muscle, causing lid retraction. So let's take the previous example into action. Let's say this is the parasympathetic system of the eye. So the center is Edinger-Westphal nucleus, will give preganglionic fibers that will relay into the ciliary ganglion. From then, the post-ganglionic fibers will reach the muscles of the constrictor pupillae muscle, leading to stimulation of the acetylcholine receptors or the muscarinic receptors, resulting in constriction of the pupil. Also, in the sympathetic, so if there is a drug that will stimulate this pathway, this will result in meiosis. If there is a parasympatholytic or the drug that will compete with the acetylcholine for the muscarinic receptors, like for example the atropine, then this will result in mydriasis, and this is called a parasympatholytic. Vice versa, if there is here the lateral horn cells will through which the from the cerebrospinal center of Budge from C8 to T2, the preganglionic fibers will pass until they relay in the superior cervical ganglion. Then the postganglionic fibers will pass to reach their effector organ, like for example the dilator pupillae muscle, causing stimulation of the alpha 1 receptor in the dilator pupillae muscle, leading to dilatation. So this is the action of the sympathomimetic, causing mydriasis. But if we put a sympatholytic, that will result in meiosis rather than mydriasis. So the example for the sympathomimetic will be the adrenaline, for example. The example for the sympatholytic is a drug called the guanethidine. So let's have more information about myotics and mydriatics. The myotics are the drugs that will constrict the pupil. They are called myotics. So as we now understand, the myotics can be either by stimulation of the action of constrictor pupillae muscle through the parasympathomimetics, or by inhibition of the action of dilator pupillae muscle through the action of sympatholytics. So which is more common if we want to myose the pupil? Is it the parasympathomimetics or the sympatholytics? Can you tell me in the chat box? Hello, can you hear me? Yes, exactly. The parasympathomimetics are much more common. So what are the parasympathomimetic drugs? The parasympathomimetic drugs are cholinergic drugs because they will act like acetylcholine on the muscarinic receptors. So they will have the same effect like acetylcholine. Either they will initiate or stimulate the acetylcholine, either they will act like it is, or they prevent its breakdown. So according to the mode of action, we have what's called direct and indirect. Direct acting or agonists are drugs that have the same effect or same structure like acetylcholine. For example, the pilocarpine. So the pilocarpine, when it is given to the eye, then the pilocarpine will act on the constrictor pupillae muscle as if it is acetylcholine, causing stimulation of the muscarinic receptors, causing contraction of the constrictor pupillae muscle. Or there is another mechanism, which is an indirect mechanism in which we increase the abundance of the acetylcholine in the receptors, which is by inhibition of the cholinesterase enzyme. The cholinesterase enzyme is an enzyme that will break down the acetylcholine as a negative feedback mechanism. So by inhibition of this enzyme, this will lead to that the acetylcholine will be much more abundant in the neuromuscular junction. So we destroy the enzyme that destroys the acetylcholine. This can be either reversible, which is the physostigmine, or the irreversible, which is the icosapent iodide, which is what's called the organophosphorus poisoning. You remember, you're present in the pesticides. This will cause the irreversible increase of the acetylcholine. Or there are some drugs that will have dual action. They will act by both direct mechanism and indirect mechanisms, like the carbachol or the mycol that is used intraoperative. It will inhibit, it will act as acetylcholine, so it will act like a pilocarpine, and it will prevent the enzyme that will break down the acetylcholine, so it will inhibit the anticholine, it will inhibit cholinesterase, or it will have an anticholinesterase receptor. It will increase the acetylcholine amount at the neuromuscular junction, causing constriction of the pupil. So here is the neuromuscular junction. This is the presynaptic neuron and postsynaptic neuron. The acetylcholine is released into the neurosynaptic junction to act on the acetylcholine receptor. So the pilocarpine will act by the same effect. So the pilocarpine is now called an agonist. It is an agonist which is acting on the receptor of acetylcholine receptor, leading to stimulation of the muscarinic receptor. And there is another mechanism, which is the acetylcholinesterase will break down the acetyl molecule to choline and the acetate. So by inhibition of this enzyme, this will increase the amount of acetylcholine in the receptor, causing a potentiation of its action. The other form or the other modality of constriction of the pupil is called the sympatholytic drugs. It is only one drug, and which is no longer even available and no longer used. It is called the guanethidine. So you just know its name and you just know its action, but you need no more information needed about it. It will cause depletion of stores of noradrenaline from the nerve terminals. So at the neuromuscular junction or the nerve terminal, there will also when the sympatholytic drug is administered, it will cause depletion, it will cause extension of noradrenaline from these nerve terminals. So when these stores are depleted and vanish, then the aqueous humor formation is reduced due to their effects on the aqueous production, and the pupil become myosed. So the pupil can be constricted by another mechanism, but it is not that common, or not. It is not in the practice is used. The second effect or the second mechanism of the pupil is called mydriatic or the mydriasis. It is just dilatation of the pupil. So we have two drugs that will cause mydriasis of the pupil, either the parasympatholytic by constriction, by inhibition of the constrictor pupillae muscle, or the sympathomimetic. The sympathomimetic are drugs that will stimulate the dilator pupillae by direct action. So let's see what are the parasympatholytics and what are the sympathomimetics. So here, let's say, what is the main difference between the parasympatholytics and the sympathomimetics? So both will result in mydriasis, but there is a crucial difference between both of them. Can anyone have a guess the difference in action between the parasympatholytics and sympathomimetics? Since that by inhibition of the parasympathetic or stimulation of the sympathetic. Let me save you from thinking. The parasympathetic system is present in two areas, while the sympathetic is present in one area specifically. The parasympathetic is present in the iris, in the sphincter pupillae, and in the ciliary muscle, while the sympathetic is present in the iris. So although the sympathomimetic can dilate the iris and the parasympathetic can dilate the iris, but the parasympatholytic can relax the ciliary muscle by inhibition of the parasympathetic, as the parasympathetic stimulation will constrict the ciliary muscle. The parasympathetic inhibition will relax the ciliary muscle, while the sympathomimetics have no role on the ciliary muscle. That's why the parasympatholytics are causing mydriasis in association with cycloplegia, while the sympathomimetics are only causing mydriasis. So let's see what are the drugs. The cycloplegics are the drugs that will cause relaxation of the ciliary muscle, which are parasympatholytics, which is starting from the drug which has more extended duration, which is atropine, to hyoscine, to homatropine, cyclopentolate, and the tropicamide. These drugs are called the parasympatholytics, so they will antagonize the effect of acetylcholine at the constrictor pupillary muscle, and they will result in dilatation of the pupil, and also they will relax the ciliary muscle, causing and has a most extended duration, like here. And as we go down, the hyoscine are weaker than atropine, homatropine are weaker than hyoscine, cyclopentolate can only stay for 24 hours, while the tropicamide, which is the most rapid eye drop, has the slowest or has the weakest cycloplegic action. So the strongest cycloplegic action is coming from atropine, the weakest cycloplegic action from tropicamide, but the atropine has the most extended duration and the tropicamide has the least duration, as it's very, very rapid. It can even start within less than 30 minutes. So the same list here of the cycloplegics will be on the dilators, but adding to them another drug. So atropine and hyoscine and homatropine and cyclopentolate is this sympathomimetic, which is the phenylephrine. So phenylephrine, it is a sympathomimetic, but it is not a cycloplegic. Or it is a mydriatic, but not a cycloplegic. So let's talk about the parasympatholytic mydriatics. So after a revision of the previous table, as we said, the atropine will be the strongest mydriatic and the strongest cycloplegics. So it will relax the sphincter pupillae muscle, it will relax the ciliary muscle, but it has its side effects. These side effects are the side effects of blockage of the parasympathetic system, meaning that the patient may complain of dry mouth and dry skin, difficulty in swallowing, tachycardia and tachypnea, flushing, so he feels hot and he feels hyperpyrexia and confusion, and even sometimes can cause coma and convulsions and death. So atropine shouldn't be underestimated. Homatropine is a weaker drug. It has a shorter action than atropine, and also it has less side effects. The cyclopentolate, which is the commonly used cycloplegic in the most commonly used cycloplegic in the ophthalmic practice for older population or older patients, it has a short-acting cycloplegic as it acts for only 24 hours and doesn't have any peripheral side effects. Tropicamide is, or the midriacid or the mydriatic eye drops, it is a quick and short acting with rare side effects, and usually it is used as a mydriatic or dilating eye drop rather than a cycloplegic. If we want to give a cycloplegic for the patient, then cyclopentolate will be of choice for younger adults, for older adults, and for atropine, it is reserved usually for the children. The sympathomimetics dimidriatics, these are causing stimulation of the dilator pupillae muscle, as we said, is the phenylephrine. This is the only drug which is used in ophthalmology. It is the only sympathomimetic that is used clinically, and it has only alpha-1 activity. And this is good because we have only alpha-1 receptors in the dilator pupillae muscle, so that we need only alpha-1 activity. Because if we use a generally acting sympathomimetic like adrenaline or epinephrine, it will have both alpha and beta activity. And this is not good because if we give a beta-2 activity, the beta-2 activity is not required for pupil dilatation. As we mentioned, there is no beta-2 receptors, but it will undergo systemic absorption and will cause adrenergic receptors, or sorry, it will lead to adrenergic response, leading to the sympathetic stimulation that we will talk about in the glaucoma. So that's why this is one reason why we are not using the adrenaline epinephrine. Also, the dilator pupillae itself is not a powerful muscle. So if we want to have a full dilatation, it is not logic or not wise to use the phenylephrine alone, but we combine it with another parasympatholytic. So a sympathomimetic alone is not efficient for complete dilatation, but we add another parasympatholytic like this drug or this eye drop is called cyclophrine, in which there is an association or there is conjunction of the phenylephrine with the cyclopentolate. So phenylephrine can cause stimulation of the dilator pupillae muscle. Cyclopentolate will cause inhibition or antagonize the effect of the constrictor pupillae muscle. So this will be the dilator pupillae muscle. So this is the diagram that we saw before while we were discussing the Horner syndrome, and this is the nerve, the postganglionic sympathetic nerve, showing the norepinephrine which is released through the synaptic junction, acting on the alpha-1 and beta-1, alpha and the beta receptors. Then it will be reuptake and it will be destructed by monoamine oxidase, and some will go to the plasma. So this is the end of the first lecture. Do you have any question? Do you have any question in the previous part? Okay, thank you. So I hope that this part or the previous part was easy somehow and was well illustrated. So is the voice clear and the screen is okay, or is